Hello students, now I will show you another X-ray plate. This X-ray film, it is the X-ray of the knee region. This is in anteroposterior view and this is in lateral view, and both are plain X-ray or straight X-ray. So what are the bones and joints we can see in this particular film? This is the lower end of the femur and this is the condyles of femur. Upper end of tibia with condyles, upper end of the shaft of the tibia, and this is the upper end and some part of the shaft of fibula. So in this film, in this view, we can see another bone. This is patella. This is the lateral view. So in the lateral view, we can see the patella more clearly because here the patella is superimposed on the lower condyle of femur. Then what are the anatomical points or anatomical landmarks we see in the femur, tibia, fibula and patella? This is the shaft, this is the compact part, more dense, and this is the spongy part, less dense. This is medial condyle, this is lateral condyle. And if you trace this from the medial condyle, this line, it extends towards the shaft of the femur called medial supracondylar line. Similarly, on the lateral side, another line is there. This is called lateral supracondylar line. Where the medial supracondylar line ends, there is a bony projection, small bony projection. That bony projection is called adductor tubercle. And what is the importance of this adductor tubercle? Number one, the epiphyseal line of the lower end of femur passes through the adductor tubercle. Number one. Number two, it is an important landmark for surface anatomy. Number three, here is the attachment of the ischial fiber of adductor magnus, and also it is the attachment site of the tibial collateral ligament. The tibial collateral ligament extends from the adductor tubercle to the upper end of the tibia. So these are the important anatomical importance of the adductor tubercle. Then we can see the epicondyle. There are two epicondyle, medial and lateral. This is lateral side, this is medial side. So on the lateral side, most projecting bony part from the lateral surface of lateral condyle is called the lateral epicondyle here. And on medial side, the most projecting bony part from the medial surface of medial condyle is called medial epicondyle. So there are two epicondyle, medial and one lateral. But of these two condyle, which condyle is more massive? The answer is lateral condyle. This one is more massive than the medial counterpart. Why? Because this lateral condyle, it shares more in weight transmission from femur to tibia, and in between these two condyle is the intercondylar area. In this field, you can see this is one condyle, this is the margin, this is the outline, and another condyle is this one. This is the outline of another condyle. In between these two condyle, posteriorly we can see the intercondylar area, and anteriorly there is a surface for the patella, because patella would articulate with the femur in between the two condyles. Then come to the tibia. In the tibia, what we can see? In the tibia, in the upper end, there are two condyles. Again, this is medial condyle, this is lateral condyle. And in between these two condyles, there is an area or intercondylar area. In the intercondylar area, there is two prominence. That is called intercondylar prominence or intercondylar eminence. This is intercondylar eminence and this is intercondylar area. What are the structures attached at the intercondylar area or in between the two eminences on the upper surface of the tibia? The answer is very simple. It is commonly asked. from anterior to posterior, the structures are the anterior end of medial meniscus, then anterior cruciate ligament, then anterior end of lateral meniscus, then posterior end of lateral meniscus, then posterior end of medial meniscus, and then posterior cruciate ligament. So these 6 attachments are there from anterior to posterior, and we will get meniscus over the medial condyle and lateral condyle. This meniscus is nothing but the fibrocartilage which intervenes between the articular surface of the femur and articular surface of the tibia. So on the upper surface of the medial condyle, medial meniscus, on the upper surface of lateral condyle is the lateral meniscus. Below the condyle, on the anterior aspect, there is a prominence here. In lateral view, this is the prominence, which is more prominent or more clear in the lateral view. This prominence is called tibial tuberosity. So tibial tuberosity, here is the attachment of some important structures. What are the attachment of tibial tuberosity? Here you will get the attachment of the ligamento patelli. So ligamento patelli extending from the apex of the patella to the tibial tuberosity. Of these two bones, tibia and fibula, which one is massive? It is clear from this film. The tibia is more massive than the fibula. Why? Because the tibia, it transmits more weight than the fibula, where a negligible weight is transmitted through the fibula. So tibia representing the preaxial bone and transmits much of the body weight than the postaxial leg bone fibula, which transmits less weight. So it is thin and it is stout or massive. The tibial tuberosity, it belongs to the upper epiphysis, as the upper epiphyseal line, it extends or descends to include the tibial tuberosity, like this. Then what are the joints formed by this 1, 2, 3 and 4 bones? This is the knee joint and this is the joint space. That means here you will get the cartilage. Because cartilage is radiolucent, it looks black, and the type of the joint is the synovial joint. But the knee joint, it is not only formed by the tibia and femur, it is also formed by the patella. So tibia, femur and patella, these 3 bones form the knee joint. We know if any joint is formed by more than 2 bones, it is called compound joint. So knee joint, as because it is formed by 3 bones, it is an example of compound joint. And at the same time, it is also complex joint. Complex joint means when a joint cavity is divided by a fibrocartilage into 2 compartments, it is called complex joint. And you know, here is the meniscus or fibrocartilage, which divides this joint cavity into suprameniscal compartment and inframeniscal compartment. So it is an example of both compound joint and complex joint. And I told you it is a synovial joint, but subtype is uniaxial condylar joint. Sometimes it is asked why it is called a modified hinge joint. So before discussing modified hinge joint, we must know what is a hinge joint. A hinge joint is one where there is around a fixed transverse axis, flexion and extension occurs. But in the knee joint, the transverse axis is not fixed. Rather, it moves forward and backward. Moreover, a conjunct type of rotation occurs in the knee joint during extension and flexion. The rotation occurs of the femur on the tibia or tibia on the femurs around a more or less vertical axis, and that axis is formed by the taut anterior cruciate ligament. So it is called a modified hinge joint because other than the flexion extension, some sort of conjunct rotation occurs in this joint. This is femoropatellar joint. So this is the posterior surface of the patella, it articulates with the intercondylar area in the lower end of the femur to form the femoropatellar articulation. So here is this joint space between this patella and femur. Then come to the tibiofibular joint. Here there is one facet on the tibia as well as on the fibula. On the tibia, on the lateral side, rather on the posterolateral side of the lateral condyle of the tibia, there is an articular facet here, and also there is an articular surface of the head of the fibula, which forms the superior tibiofibular joint, which is a plain type of synovial joint. Besides this, the tibial fibula having other joints too. In the middle, that is middle tibiofibular joint, which is an example of syndesmosis type of fibrous joint, and inferior tibiofibular joint, which is again a syndesmosis type of fibrous joint. And what type of bone is a patella? Very simple question, but it is frequently asked. It is a sesamoid bone. Rather, it is the largest sesamoid bone in the body. Then what do you mean by sesamoid bone? The sesamoid bone having some special characteristics. Number one, it ossifies from the secondary center of ossification, that is after birth, and it ossifies under a tendon. The patella ossifies under the tendon of quadriceps femoris. And the sesamoid bone, it is devoid of periosteum, and fourthly, it is devoid of Haversian system. You may be asked, can you give example of other sesamoid bone in the body? Yes, in the upper extremity or rather in the hand, the pisiform bone in the tendon of flexor carpi ulnaris is another example of sesamoid bone. You must remember two examples, one from the upper extremity is the pisiform bone under flexor carpi ulnaris and patella under quadriceps femoris. And in this view, you see on the lateral side, there is an angle called the anatomical angle of the knee joint. It is the angle between the long axis of the shaft of the femur and tibia. This angle, long axis here and long axis of the tibia. So it is the angle. So it is an obtuse angle, and its value, it ranges from 170 to 175 degree. On the basis of that, there are two abnormal conditions may occur. One is genu varum or bow legs. That means in this deformity, this angle, it is increased. In that case, this is the angle, now this is increased. It is called genu varum or bow legs. And another deformity, the angle is less than 165 degree, and in this condition the knees touch one another. When the legs are straightened, both the knees or both sides, they touch together, and that condition is called the genu valgum or knock knee. So one is genu varum or bow leg, one is genu valgum or knock knee. And the importance of this deformity is that these deformities are the predisposing factors for the osteoarthritis of the knee joint. I told you of these two condyles of the lower end of femur. The lateral condyle is more massive. Not only that, the lateral condyle is projected forward to some extent, and there is a inherent tendency of the lateral displacement of patella, but it is prevented by mainly two factors. One is the massive lateral condyle, which is to some extent project forward, it prevents lateral displacement. And another point is that the prolonged lower attachment of vastus medialis up to upper two-thirds of the medial margin of the patella, the vastus medially extends, but on the lateral side, the vastus lateralis, it extends up to the upper one-third. So the prolonged and lower attachment of vastus medialis along the medial border also exerts more medial traction on the patella. This is why inherent tendency of patellar dislocation is prevented by these two anatomical factors. Regarding epiphysis of the lower end of femur and upper end of tibia, has some medical legal importance, so it is sometimes asked. The lower end of femur and upper end of tibia, they are epiphyseal centers which are called secondary center of ossification. They appear before birth, which is against the law of ossification. The law is that the primary center of ossification appears before birth and secondary center appears after birth. But here, though the centers appear before birth, they are secondary centers, not primary centers. These two are the epiphyses which appears about 9th months of intrauterine life or just before birth. It is having some medical importance to determine the maturity of the fetus. Thank you very much.